Now today I am going to talk about respiratory system. In this respiratory system, there are certain caveats that you have to remember and always remember, and I will give you some random fact that you have to remember, and that is really important. Therefore I am giving it at the beginning one. See, clubbing in COPD is never seen. Clubbing in COPD is never seen. If clubbing in COPD is witnessed, then it is due to lung cancer. Now remember that if in when we do RNTCP in our national tuberculosis guidelines, that if CBNAT first time comes positive, if CBNAT is first time inconclusive, then you have to again refer the CBNAT again, and then if then also inconclusive, if again then inconclusive, then we will go for LPA, line probe assay. Now type 2. Type 2 pneumocytes is release of surfactant and there is lamellar bodies inside. So 2 look likes S. So release of surfactant, lamellar bodies. Clara cell. Clara cell is found in upper airway respiratory tract. These are some random information that you have to anyway rectify it. So I am giving it at the start only, because after I get into these systems and ways to remember, then this kind of information I may not be able to give. Now one thing more, that we study CMIC, NMIC, LMIC. Now remember that LMIC is for small cell lung cancer. That is, here L does not go for L. That is, L does not go for large adenocarcinoma or large cell carcinoma, but here L is analogous to lung carcinoma. NMIC is for neuroblastoma and CMIC is for B and C, Burkitt's. Now after this there would be curves, criteria and all those, but now I will only touch those portions that are to be only remembered, or I have some mnemonic for it. So I will try to teach most of the system here through mnemonic. See, now what is pulmonary function test for obstructive and restrictive disease? Now remember, on one side we have obstructive symptoms and one side we have restricted symptoms, and these are the pulmonary function test, and these are the functional vital capacity, FEV1. Now FEV1 percentage. So these are the things that you would see. Now functional vital capacity, this is decreased in both of the diseases, but remember that FEV1 F1 FVC goes towards 0. This obstructive O is taken as 0, so it will decrease. Now FEV1 upon FVC will decrease. How much it will be? It would be less than 0.7, and here in restrictive disease it is greater than 0.7. So what does an obstructive disease mean? See, what happens is that this is the lung. Now what happens is that in obstructive disease, there is obstruction when there is air being expelled out of the thorax cavity. So here the problem is that there is no problem in inspiration here. The problem is in expiration. But what happens in restrictive disease? In restrictive disease, the problem is in inspiration, because the lung is not able to expand fully so that it can create a pressure and bring the air out from outside to inside. Now there is a lot of confusion regarding spirometric finding. So just remember that टाई 525 E10 R11. How you will decode it? Now tidal volume, total lung volume here would be 5 liter. Inspiratory reserve volume 2.5 liter. Expiratory reserve volume 1 liter, and residual volume 1.1 liter. So by this this line in type 525 E10 R11, type 525 E10 R11. Just remember multiple times, and then you will be able to recall each and every part of this spirometry. Now moving ahead, just see that tidal volume is in between, so it would be 5 liter. So tidal volume, this is normal respiration without any extra force it is going on. But suppose if we apply a great intrathoracic pressure, then it suddenly will go up, and we supply full forced so that the air is expelled out, so it will come here, and then again this will continue. So now from the above you will remember that I have taught you that how to remember all the lung volumes. Now I avoid what I have to do is just I have to fit in all the things that are there. Now tidal volume, now total lung volume. Now from total lung volume we know that total lung volume is 5 liter. Inspiratory reserve volume, now inspiratory reserve volume would be what? This would be inspiratory reserve volume, that would be 2.5 liter. Now we have expiratory reserve volume, that will be around 1 liter. Now this is expiratory reserve volume, that is 0.5 liter. And then there is a residual volume 1.1 liter. And from that you can add everything and each and everything. For example, if you add inspiratory reserve volume plus tidal volume, IRV plus tidal volume, you will get inspiratory capacity. Now we move on to the spirometry. What we will get in spirometry? See, I have told you that an obstructive FEV1 upon FVC would move towards 0, that is less than 0.7, and for restrictive it will be normal. Now in this, if this is, then we are talking about restrictive. If this is this, here talking about obstructive. Now for obstructive, we put in the bronchodilator challenge. Now in bronchodilator challenge, if it is greater than 12%, if it is greater than 12%, then it represents bronchodilator challenge. Now if FEV1 is greater than 12%, then it is asthma. And if there is no change in FEV1, no, there is no change in FEV1, then we are dealing with conditions something that is non-reversible. So now we will see whether there is what is the diffusion across the alveoli. So DLC of diffusion of capacity in the lung of carbon monoxide. So what will we say there would be normal gas barrier, so chronic bronchitis. And if the gas barrier is impaired, then it would be emphysema. Why I say so? Because remember that this is alveoli. So what is happening is that in emphysema, this is all getting destroyed. When this all getting is destroyed, then there would be very less interface that would bring about the change in oxygen. So ultimately the gas barrier is gas diffusion along the gradient is impaired. So just remember that when diffusion capacity of carbon monoxide is less, then it points toward emphysema, and when then it is normal, then it points toward chronic bronchitis. Now for restrictive disease, remember that again here we will go for DLCO, and now here what we will do is, if diffusion capacity around the curve along the lung is normal, that means that there is nothing problem in the lung, but there is some external problem. So exterior muscular compartment is to be seen, and that occurs with kyphoscoliosis, obesity, myasthenia gravis. Now we have decreased diffuse lung carbon monoxide, and there is reduction in diffusion. So now, in which case pulmonary fibrosis, pulmonary edema, asbestosis. Now we come on to the flow volume curves. In flow volume curves, often there is misunderstanding. First you understand the what are the markings, then automatically you will be able to understand the flow of oxygen through it. Remember that this is this. Now what will happen is that this is showing the expiration portion and this is showing the inspiration. But one thing that is abnormal from all other graph is that here, as we move towards left, the value will keep on increasing. So here it is 0, here it is 2, it is 4, it is 6, and it is 8 here. So that is the point of difference. Many times flow volume curve is not understood just simply because we are not seeing it in the opposite direction. Now what we will do, what our normal respiration would look like. So here it would be, this is expiration and then we will have inspiration. So this is what it would look like, but in a normal curve. But what will happen in obstructive disease? In obstructive disease and in restrictive, first let us go through restrictive disease. So in restrictive disease, you understand that the inspiration, the amount of air that is coming inside the lung is already very low because lung is not able to bring all the oxygens. So what will happen? And also remember that the residual capacity would be low also. So here from here the lung will expand and then it reaches its maximum value. Now from here what will happen is that the restriction. Now from here the lungs will expire. So what do you understand from? Firstly, what is this point known as? This point is known as residual capacity. Why residual capacity? See, we are plotting the point from right side. Here it is 0. So as we move gradually towards left side, then what will happen? We get the first lung volume, that is minimum at the time of full expiration, that is residual capacity, and then it gradually increases to reach here, and that will be total lung volume. Then what will have we seen in obstructive lung disease? In obstructive, remembers, inspiration is normal, so inspiration would occur normally. So what we will see in this, inspiration is normal, so it is going, and inspiration, it is normal. Now what happens is that after obstructive disease, fine. Now let us move on to the flow or low volume curves. Now flow volume curves, remember. Now flow volume curves, so what is the trick to remember is that in obstructive, what we get leg is scooping pattern. Okay, if you will not allow dog to go outside in the street, then it will do toilet inside only. So just remember this through. Yeah, this is dog scooping pattern and this is inspiratory reserve volume. Now this is volume. Now this is expiratory. Now this is inspiratory flow. Now this is total lung capacity and this is residual volume. So this is of obstructive pattern. Now we move toward now on the same page I will be showing you different graphs. Now again, now in cases of fixed airway obstruction, now in fixed airway obstruction, there is obstruction to both inside as well as outside. So what will this will flatten out the graph. So what will be seen in this? There would be this. Now total lung capacity, residual volume. Now there could be fixed airway obstruction and this can be lead to laryngospasm, tracheal stenosis. Now we move towards variable extrathoracic obstruction. What will be there? Now in variable extrathoracic obstruction, the inspiratory would flatten out. Just remember that. What would be the extrathoracic obstruction? See, for example, there can be vocal cord obstruction. Vocal cord here, it will not allow the gas to pass if there is recurrent laryngeal palsy and ultimately vocal cord palsy. So what will happen? Air will not be able to move out. So here this is cross mnemonic. Now when we have variable extrathoracic, now we have extrathoracic, then the inspiratory would flatten out. Just remember that. This will be for the variable expiratory. Now when there will be variable intrathoracic obstruction, so what will happen here? Here there would be variable intrathoracic obstruction. Now when variable intrathoracic obstruction, then the extrathoracic one will flatten out. Variable intrathoracic obstruction. Now what is minute ventilation? Now minute ventilation is equal to tidal volume into respiratory rate. What is alveolar ventilation? Now see, in alveolar ventilation what we will do? Respiratory rate is equal to Now in alveolar ventilation, what you will do, you will be subtracting the whatever this dead space oxygen is there. So here it is the tidal volume minus the volume, the dead space volume of the lung. So into respiratory rate. From that you can derive your alveolar ventilation. What is oxygen carrying capacity of the blood? Now oxygen carrying capacity of blood is oxygen carrying capacity is equal to hemoglobin bound oxygen plus partial pressure of the oxygen into 0.0031. And what will we see, remember what is this, what will be the oxygen carrying capacity? Now oxygen carrying capacity would be hemoglobin bound oxygen plus dissolved oxygen. Now how much is the dissolved oxygen? Now dissolved oxygen is, first we will take the carrying capacity. Now what is the carrying capacity? Is that 1.34 into hemoglobin plus partial pressure of the oxygen into 0.0031. So hemoglobin concentration, saturation of oxygen, partial pressure of the oxygen, and total oxygen content we will see. Now what will happen in carbon monoxide poisoning? What will happen in carbon monoxide poisoning? In carbon monoxide poisoning, hemoglobin concentration would be normal, saturation of oxygen normal, and then total oxygen content is decreased. Why saturation of oxygen is lowered? Because carbon monoxide is binding to oxygen, but partial pressure of the oxygen is still the same, and the total oxygen content is still the same. Now we come in anemia. See, in anemia, what happens that hemoglobin concentration is decreased, so saturation of oxygen, you cannot comment much upon pressure. Comment total oxygen content is decreased. Now in polycythemia, what happens in polycythemia? Hemoglobin concentration is decreased and it is increased. Now cyanide toxicity, it is normal here, because it is an in cyanide toxicity, hemoglobin concentration, saturation of oxygen, partial pressure of oxygen, and total oxygen content is all normal. Why? Because the problem is in the electron transport system. The oxygen carrying capacity system is absolutely fine. So here there is problem in the cyanide toxicity. Now we come on towards the oxygen or hemoglobin dissociation curve. So remember, the oxygen hemoglobin dissociation curve is very often asked. And remember, firstly we cover the points that we have to mug up. See, shape is sigmoidal, and there is positive cooperativity. Now partial pressure of oxygen when it is saturation 50%. When the hemoglobin is saturated 50%, what is the pressure? That is 26 millimeter of mercury. That you will have to remember. Just remember this information. Now remember this. So how oxygen hemoglobin dissociation curve. Now this is our sigmoid oxygen hemoglobin dissociation curve. Remember now what you will do, anything that is small, that has a small, that is HbF or pH or myoglobin or carbon monoxide, it will do left shift and others will do right shift. Just remember that anything that has a small name, they will pull it towards left, and rest you can learn easily. There's a popular mnemonic that you can remember, Gita, but I don't find it much usable because you need to know the full form, and this one is more handy. Like those who are 2 or 3 letter words, they will bring left shift. But remember that 2 3 bpg will do right shift. And what is I'm talking about, it is about increasing the concentration. Like what will happen if the HbF concentration is increased, pH is increased, myoglobin is increased, carbon monoxide is increased. Now remember, there is one mnemonic here, that is Gita. Now for G you have gene growth hormone, for E you will have exercise, for T is thyroid, for A is altitude, A is androgen, and A is anemia. Now we come towards the respiratory patterns. Now respiratory patterns, remember that a normal respiration what it will look like. A normal respiration would look like this. Now what happens in Biot's respiration? In Biot's respiration, what happens is that there is hyperapnea followed by apnea. Now what happens is there is hyperapnea, and then there is apnea, then there is hyperapnea. So biots have brain, biots respiration is in by brain, and that occurs in CNS. Now we move towards the Kussmaul breathing. See, Kussmaul breathing is nothing but there will be increase in the amplitude. What will happen in Kussmaul breathing? There will be increase in the amplitude. Crescendo will have Cheyne-Stokes respiration. What you can remember that crescendo. Now we come towards the respiratory regulation. Now respiratory regulation, there is a lot of confusion, and uh, I will teach you the analytical way, but first remember the points that can be asked. See, remember that MDA, Ministry of Drug Administration, or something like that, you can remember MDA. Now what happens in mid-pons section? In mid-pons section, what will happen if the 10th nerve is intact? When the 10th nerve is intact, then there will be increase in depth of respiration. But when the 10th nerve is not intact, when 10th nerve is not intact, then it leads to apneosis. This is one point you please just learn and mug it up, because questions are going to be largely framed around here, and we are going to make mistakes around here only. So remember that MDA. Now whatever you have to understand, now I will go towards that side. And also there is a mnemonic, that is DIE, that is dorsal is for inspiratory, ventral is for expiratory, but I would like to change it a bit because a question has been asked, and people were finding it difficult to answer. So just remember, we can write this word as DIFE, that is dorsal is responsible for inspiration, but ventral do not take part normally. Now when ventral do not take part normally, so what happens in ventral? Ventral is responsible for forced expiration. Now forced expiration, ventral is responsible. What happens is that now again we move towards the pons medulla section. There is irregular breathing, and below medulla breathing ceases. Above pons, there's no point, because in above pons you remember that there is voluntary control. Now we come on to the mechanism, how to understand the mechanism. You must have studied the P10 genes. Now P10 genes, just remember that it can be divided into two. The one is the pneumotaxic center, and the other 10 is the cranial nerve, that is vagus. So what happens is pneumotaxic center, what it does is pneumotaxic center, it increases the rate, and it increases the rate, and it also stimulates the apneustic center. Now what does apneustic center? It increases the depth. So pneumotaxic center inhibits the apneustic center. But what happens is that 10th cranial nerve also stimulates the apneustic center. So when 10th nerve is cut, then the apneustic center is not inhibited, and when it is not inhibited, then there will be increase in the depth of the respiration. So what is there? So it is pneumotaxis center is inhibiting, cranial 10th cranial nerve is also inhibiting. So remember that if either of gets damaged, then the inhibition would be less, then there would be increase in depth. But when both P10, that is pneumotaxic center, and 10th cranial nerve is lost, then ultimately this APC is dominant, and when this APC is dominant, then it will stimulate apneosis. So that after understanding the whole thing, what we would come to the conclusion that in mid-pons section, if vagal nerve is intact, then the depth would increase. When the vagal nerve is not intact, then the depth would, and then there would be apneosis, and there would not and that will result in increase in that what I have first said in MDA, that at mid-pons section, because invariably question, if they are going to frame from here, just remember that nerve intact is increases the depth. If nerve is not intact, then apneustic center. So remember that if both are active, that is P10 is both are active, then normal respiration. If anyone gets damaged, then apneustic center is not inhibited that much, and this results in increase in depth. But if both P10 is damaged, then what will happen? There is no inhibitory signal to apneustic center, and apneustic center gets activated. When apneustic center gets activated, what will happen? It will manifest as apneosis. Now, a question was asked that young couple was spending their afternoon on a picnic. There was a young couple who went for a picnic. Now, what happens? Woman proposed the boy. Man was taken aback and he hyperventilated. So, question was, the overdrive mechanism observed is due to why he is hyperventilating? Why is there overdrive mechanism that is when? So, remember that normal circumstances, ventral group of neuron will not come into play. But when there is forced expiration, then ventral group of neurons will come into play, and therefore here the answer would be ventral group of neurons in medulla. Now we come towards sleep apnea. Now in sleep apnea, what will happen is, the question would be that how to differentiate between the central cause of sleep apnea or the peripheral causes of sleep apnea. You have to just remember that if what is central apnea? When there is no impulses from the central CNS. What is peripheral? That is the accessory muscles that is responsible for inspiration. They are not working. So what is what is happening is that in sleep apnea, if the muscles are working, the peripheral muscles are working, that is rectus abdominis and the transversus abdominis muscle, but still there is no inspiration. So it means that the problem is in the inspiratory tract, and that is the peripheral obstruction. But what happens if there is no activity of the muscles altogether? Muscles is lying flat. So what is this? What does this show? This shows that the brain is not able to send impulses to the peripheral these muscles, and therefore the causes of apnea here is central. Now we come towards pleural effusion. Now pleural effusion, just remember these are the certain criteria that you will have to remember. That is, see, it arrange first write protein, pleural protein upon serum protein, pleural LDH upon serum NDH. So this is greater than 0.5, this is greater than 0.6, and LDH is 2/3 of protein, 2/3 of LDH in the blood. Now remember that what are the through this lights criteria. Just remember, just arrange that in this order. Then you will recall the lights criteria. This is lights criteria, and if the value is more than whatever is written here, then it is exudative and otherwise transudative. Now remember that in C, when for the purpose of mnemonic, that would remember that REM is the condition where pleural glucose is reduced. So how will you remember that? When there is rapid eye movement, then ultimately what is happening? That rapid eye movement, ultimately there is a lot of function being carried out by the eye, but still there is not much there, but still glucose is less. So how you can remember? There are three conditions by rheumatoid arthritis, empyema, and malignancy. Now for high amylase, you remember that for amylase, esophageal rupture, because amylase is an enzyme that is present in our digestive tract. And then there is pancreatitis, and then there is malignancy. Now we move towards the chylothorax. Now what is chylothorax? In chylothorax, there is greater than 100 milligram per deciliter of triglyceride. Now pseudocylothorax and pseudocylothorax. In pseudocylothorax, rheumatoid arthritis refers to cholesterol. Now move on to the respiratory failure. Now how to remember the respiratory failure? See, respiratory failure is of mainly 4 types. Now first is there is hypoxemia. Second type of respiratory failure is that there is hypercarbia. Third type is perioperative, and fourth is due to shock with hypoperfusion. Now remember that is an hypoxemia. There is ultimately low oxygen being delivered. So what are the conditions? Consolidation, pneumonia, pulmonary edema, ARDS. Now what will happen in hypercapnia? You can remember it by the mnemonic COPD. where C is for central respiratory drive is absent. O is for obstruction in, that is COPD. Now type 3 is perioperative and type 4 is shock with hypoperfusion. Now let us discuss the ARDS. Now remember that ARDS is a problem of respiratory system. So what can be the criteria? If you are yourself have to make the criteria, how will you make that? There should be non-cardiogenic edema, and acute, for acute that is to be less than 7 days. For respiratory there should be non-cardiogenic pulmonary edema. For distress, you can these two things can be remembered for the diagnostic criteria of ARDS. Now remember how you will, now in ARDS you can remember that acute can be depicted by less than 7 days, respiratory that is non-cardiogenic edema, and there is ultimate distress. How can we document that distress? You can document that distress by showing the chest x-ray that will have bilateral opacities consistent with pulmonary edema and not explained by effusion, lobar lung collapse or nodules. And one of the other condition is there should be absence of left arterial hypertension. See, if there is left arterial hypertension, that means the blood coming from the heart is in hypertension phase. That is, one should be thorough with that there is normal pulmonary capillary wedge pressure, because pulmonary capillary wedge pressure is basically for knowing the pulmonary artery pressure. If there is pulmonary artery hypertension, then this would be high. Now and there is chest x-ray that you need to see, and there is bat wing sign. Now what happens in cardiac ARDS? What happens is that there is pulmonary edema, the cardiac width upon the thoracic width that was increased, and there would be appearance of bat wing sign. See, this is bat wing sign, and there is pulmonary effusion occurring peripherally. Now, how will you proceed ahead? Now, how will you classify the severe on the basis of severity of this ARDSC? Fractional inspired oxygen is, that is, for example, 21% is the normal fractional inspiration of oxygen. That means when we inspire air, the 21% of it is oxygen, but that ratio can be altered in case of ventilator. In case of ventilator, that ratio can be altered. So whatever when we increase the fractional inspired of oxygen, that is increasing the amount of oxygen, and ultimately that would increase the fraction of the inspired oxygen, then what is the concomitant effect on the partial pressure of the oxygen? So how will you remember it? So remember that if PaO2 upon FiO2, if it is less than 100, that means a normal that means, see, just remember that if FiO2 and PaO2, if fraction of inspired oxygen, this is less, this is not much more, but partial pressure of the oxygen is a lot more, that means that the system is working highly efficiently. Therefore, if it is in the ratio of 200 to 300, then the disease is said to be mild. Now in moderate, what will happen is that if it is in the ratio of 100 to 200, then it is in moderate. And if it is in the ratio of less than 100, then it is severe. Remember the signs that we see, that is the bat wing sign, pulmonary edema, bat wing sign, cardiomegaly, pleural effusion, curly AB lines. Now we come towards the pulmonary embolism. Now in pulmonary embolism, you should remember that what is the most sensitive test? It is the D-dimer test. Now if it is stable, you will give a anticoagulant, and if it is contraindicated, then we will put IVC filter. If it is unstable, then you will give anticoagulation plus thrombolytics, and if it is contraindicated, then it will lead to embolectomy. See, what is the difference that you should remember for here is that they are often asking Wells score. Now remember, for Wells score, if they give a history of DVT, then rest assured that it would be pulmonary embolism, because alternative diagnosis less likely than pulmonary embolism. That also carries a 3 point, and therefore for all practical purposes, remember that it would be less. Now we do echo. What happens in echo? Now echo, we get the McConnell sign, in which the right ventricular free wall is not moving. Now what is the ECG finding that we get? ECG finding that you should know about pulmonary embolism is that, just can remember part of the Saket. Now what happens is S1 Q3 T3. This is the ECG finding. So it can be learned by the word Saket. So Saket have Akimatra. So we can put it here 1. Another can be 3. Now we move towards the pulmonary arterial hypertension. Now what is pulmonary arterial hypertension? Just remember that in classification 1 there is HIV, cystosomiasis, crest-like features. Classification 2, there is a left ventricular heart, so there is presence of left heart diseases. Now remember, because heart is bilaterally symmetrical, that is, it is divided into 2 sets. Now for third, you can remember that lungs, 1 trachea, and then total number of items 3. See, for lungs there is a trachea and then 2 lungs. Therefore, it comes out to be 3. So pulmonary arterial hypertension owing to lung disease and or hypoxia. And now fourth is chronic thromboembolism. Now, how you will give the treatment in pulmonary arterial hypertension? So remember that the first step is DOD. What is DOD? We give diuretics, oxygen, anticoagulants, and digoxin. Diuretics, oxygen, anticoagulation, and then you will have digoxin. Now, what we will do? We will do acute vasoreactive testing. Now we will do acute vasoreactive testing. Now if vasoreactive testing is positive, then we will give oral CCB. If it is negative, then what we will give? We will define it into lower risk and higher risk. Lower risk and higher risk. Now in lower risk, what we have endothelin receptor, and in low risk, what will you go to? You will give endothelin receptor antagonist or phosphodiesterase inhibitor 5 inhibitor. Now you can give treprostinil and iloprost. Treprostinil and iloprost. Later on, if this does not work, but in higher risk, we will right away start with epoprostenil. Now epoprostenil and treprostinil. Now either you go for atrial septostomy, POTS shunt, or lung transplant. Now we come towards the curve 65 criteria. Now remember that in curve 65 criteria, how to remember it? See, first is for confusion. Confusion, you will give 1 point. For uremia, remembered it will have nitrogen, and nitrogen molecular weight is 7. So if it is greater than 7, then we will get 1 point. Respiratory rate is greater than 30. All will be in the multiples of 30. Then again 1 point. Systolic BP. Now systolic BP is less than 90 and diastolic is less than 60. And age is greater than 65 years. So what will be the treatment? See, the treatment can be amoxicillin, macrolides, doxycycline. You can see, for treatment, just remember our mnemonic, that is FAB-D. It contains all the antibiotic. What are those? Either you give fluoroquinolones or beta-lactamase plus azithromycin / doxycycline. These are the drugs that you are responsible for giving in lung pneumonia, and sometimes you give erythromycin also. Now we move on to the chest infection. Now in aspergillosis, there is some primary criteria and there is some secondary criteria. How to learn the primary criteria? See, remember the primary criteria, what is it? There is hypersensitivity. So immunoglobulin E is increasing. What you will do, we will do skin test. Okay, what two criteria is already learned. Now you can, and there can be episodic bronchial obstruction. See, bronchial obstruction there would be, and then yeah. Now we move towards allergic bronchopulmonary aspergillosis. Remember that in allergic bronchopulmonary aspergillosis, all types of hypersensitivity would be seen except for type 2 hypersensitivity. That is 1, 3, 4 hypersensitivity would be seen but not 2. Now we have finger in glove sign, and we have some primary criteria. Now what are the primary criteria? Primary criteria are those that are generally involving the whole body rather than the only respiratory system. So what are the primary criteria? Remember that in primary criteria, following would be taken into consideration. Now first we are thinking of start from the respiratory tract. Okay, so what will happen that there is episodic bronchial constriction. So there would be episodes of bronchial constriction happening. Then since because it is an episodes, therefore it is called allergic bronchopulmonary aspergillosis, because this is the manifestation of allergy. What is the if we write down allergic bronchopulmonary aspergillosis, now first is allergic. Now what is the manifestation of what is the characteristics of allergy? That it is reversible bronchoconstriction. So we see episodic bronchial obstruction. Now after episodic bronchial obstruction, what we will see? We will see that there is eosinophilia. Now see, when there is constriction, here there is constriction, but in our peripheral system, what will be there? There will be eosinophilia. There will be peripheral eosinophilia. Now we move on to the third. Now third is that we will have systemic manifestation. Systemic manifestation would be skin test. Now in skin test, what will have be there? In skin test, there would be positive immediate skin test. Okay, positive immediate skin test would be there. Now after that, we have positive precipitin test to aspergillosis. Positive precipitin test. Now we will have positive precipitin test in aspergillosis. Now there will be increase in total serum. There will be total increase in serum immunoglobulin E. Now after that, what we will see is that there is history of transient or fixed lung infiltrate. Now what we were seeing till now only bronchial thing. Now we will see lungs also. Now what is happening in lung, that there is a history there you will get a history of infiltrates in the lung. Now what we will see, now there we have seen that there was bronchial obstruction, but with time many bacteria and will grow in the bronchus and there will be bronchiectasis. Now that bronchiectasis will happen. So basically proximal bronchiectasis, what we will see. Now in what is the secondary criteria? The question was asked regarding which are the primary criteria, which are the secondary criteria. Now in secondary criteria, you should remember that localized or non-specific reactions would be taken into consideration. Now what will be there? There is brown plug flex in sputum, and there will be positive late skin test to aspergillosis. This is what the aspergillosis criteria would contain. Now we come on to the fungal ball aspergilloma. Now see, this is a case of fungal ball aspergilloma. It is fungal ball aspergilloma. What we are seeing is it here. It is a monad sign. What is monad sign? See, this is what you are seeing. This is a whole cavity, and in this there is growth of aspergillus. Now when there is growth of aspergillus inside it. This will appears to us that there is a fungal ball, and but there is a small area that is not filled up yet. This is vacant area. Now this is vacant area, and this corresponds to the monad sign. That is, fungal ball will have air inside it. See, here no small black rim you would be seeing, that is the fungal wall with air. Now next move on to the and also remember that what we are saying, what is the disease here? Disease here, allergic bronchopulmonary aspergillosis. This is the disease. So what we will do in this, for allergy, what we will do, you will give steroids. For allergy you will give here steroids, and for aspergillosis you will give voriconazole. So remember, in allergic bronchopulmonary aspergillosis, whenever the treatment is asked, just treat the two A's that are lying at the extreme ends. Now we move towards the halo sign. What will happen in halo sign? You should see that in halo sign there is a central halo with this illuminescent area around it. So what that does it? So that is center. This is opaque part with the rest showing ground glass opacity. Now central is opaque with ground glass opacity. So where is it seen? It is seen in febrile neutropenia. So what happens in febrile neutropenia is that your immune system is down, and taking advantage of this, aspergillus invades your whole immune system. So what is the treatment? So will you give steroids in this condition when already your body is not is in a poor immunological state? So you will not administer steroids. So steroids is not given as was given in allergic bronchopulmonary aspergillosis. So what will you do here? Here I will only give voriconazole. Voriconazole is the only treatment that I can provide here, and not steroids that was given in allergic bronchopulmonary aspergillosis. Now we move towards the mucormycosis. Now mucormycosis is this. What is mucormycosis? In mucormycosis there is center is having ground glass opacity with the surrounding having opaque surrounding. So what will you will call? This is in exactly opposite to the halo sign. So what we will call in halo sign, what was there? There was a central illuminescent area, and then there was region of halo. But here the thing is reversed entirely 180 degree. Now the inner side is totally black and the outer region is illuminescent. So what you will do, this is basically mucormycosis. This is mucormycosis that was lot of seen in with COVID-19. Now mucormycosis have a reverse halo sign. Now mucormycosis will have reverse halo sign, and this is typical for the organizing pneumonia. Now we move towards asthma pharmacology. Now what we will see here in asthma pharmacology, according to GINA 2021 guideline, what will be there? There will be decreased inflammation, controller and reliever. By the GINA 2021 classification, we have divided the asthma pharmacology into controller and reliever. So what is happening in controller? In controller, there is decreased. We are trying to control the whole disease pathogenesis. Whereas in reliever, what we are trying to relieve the patient during an acute asthmatic attack. So what will happen in controller? You want to reduce the inflammation. You are not thinking about the episodic asthmatic attack that will happen. Therefore, what we will do, we will only give in this inhaled corticosteroids. But in reliever, what you want to relieve the patient. So we will give both long-acting beta-2 agonist, which long-acting beta-2 agonist will cause the bronchodilation. So what we will do here, we will give formoterol, that is long-acting beta-2 agonist plus inhaled corticosteroids. Now what it will do, it is bronchoprotective plus reduced inflammation. Now we move towards the what are these shots? SABA and LABA. What is SABA? Short acting beta 2 agonist. These are basically two drugs, that is salbutamol and terbutaline. Salbutamol and terbutaline. What are the long acting beta 2 agonist? Salmeterol and formoterol. Salmeterol and formoterol. ठीक है, salmeterol and formoterol. Now salmeterol is slow acting. It is slow, whereas formoterol is fast. Now, what is further understanding the mechanism of action? You should understand that what happens is that Th2 cells, what will they do? They will release the interleukin 5. Now when they will release the interleukin 5, then they will have here eosinophil. Here eosinophil is there. See, there is an eosinophil, bilobed eosinophils that is present there, and in this eosinophil there is a receptor for interleukin 5. Now that's what is called interleukin 5 alpha receptor. So at this position, two drugs will act. Now in pharmacology of asthma, you should remember that what are the steps that are responsible for inflammatory reactions. So here there is T helper 2 cells which releases interleukin 5 and which have this is eosinophil. Eosinophil can be identified by the bilobed nature here. So now eosinophil have 5 IL-5 alpha receptor. Now what happens is that there is antibodies to IL-5 as well as 5 alpha receptor. So what are those? See, we have a drug named as Banrazolimab. Now Banra is Vanar in Hindi, so he's giving high 5. So high 5 receptor, that is he's receptible to the idea of giving high 5. So IL-5 receptor antagonist would be Banrazolizumab, whereas IL-5 antagonist would be Reslizumab, Mepolizumab. See, me being a wrestler is wrestling and tackling the opposition to win 5 points. So IL-5 antagonist is Mepolizumab and Reslizumab. Resli comes from wrestle. So here the person is wrestling. From that you can remember this. Now we move on to the allergens pathway that we have in our allergens. This is mast cell. Now this mast cell will undergo degranulation to release inflammatory mediator that would be responsible for chronic and acute response. So what we will do, that is glucocorticoid that is consisting of fluticasone and budesonide inhibits the release of allergens by inhibiting its release at the cellular level. Mast cell degranulation can be inhibited by the chromones and chromolines. And then we have IgE receptor which is have anti-IgE is named omalizumab. Now here allergens will activate the mast cell and that will lead to release of mast cell degranulation, and that will release inflammatory granules that is inhibited by mast cell degranulation, that is basically chromones and chromolin. Now we have anti-immunoglobulin E, that is omalizumab. See, in omali you are getting the word E sounding at the end. Li. So E word and there is omalizumab. Now in mast cell degranulation there can be acute response and chronic response. In acute response, what will there happen? See, this is the basal bronchial tone. If acetylcholine acts on it, then it will lead to bronchoconstriction. But if a cyclic AMP acts on it, it will lead to bronchodilation. Now, cyclic AMP level can be increased by phosphodiesterase enzyme or beta 2 agonist. What will happen that how will you fight phosphodiesterase enzyme? Methylxanthine and theophylline will inhibit the phosphodiesterase enzyme and will potentiate the development or inhibit the development of cyclic AMP, ultimately leading to bronchodilation. Now what happens here? Now here what is happening is that we have acetylcholine that is acting on the bronchial muscles, so it will bring about bronchial constriction. Therefore we give muscarinic antagonist like tiotropium bromide or ipratropium bromide for asthma. Now here you see the phospholipid gives out phospholipase enzyme in the form of arachidonic acid. Arachidonic acid acted upon by 5-lipoxygenase enzyme to release leukotrienes which have cis LT1 receptor thing. And what we do is that we inhibit the formation of leukotriene by using ziliotin, which inhibits 5-lipoxygenase enzyme. Moreover, this leukotriene goes and bind to the receptor, and therefore we are antagonizing the receptor by using montelukast and zafirlukast. Now we come on to the gold criteria. In gold criteria, C category 1 is greater than 80%, category 2 is 50 to 79%, category 3 is 30 to 49%, category 4 is less than 30%. What will be the, you can simply remember is that 30 plus 50 is equal to 80. What will be the drugs that we will use? We will use LABA, LAMA and intranasal corticosteroids. Now, eosinophil content would be greater than 300 in many of these circumstances, in many of this COPD. Now, in strenuous how will you will grade the difficulty in breathing? See, if he is able to carry out strenuous exercise, then it will be category 0. Now, if he is able to up the hills, then it is category up the hill, but not convincingly. That is, he feels little bit of difficulty in going up the hill. That is grade 1. When he is not able to walk with his peers, there are two people here, so peers will involve category 2. If he is able to walk less than 100 meters, then it is categorized as category 3. And if he is not able to carry out daily routine activities like going to toilet and all, or dressing and undressing, then it is categorized as category 4. Now we come on to the SNR. See, before starting SNI, if you want to skip whole of this topic, just remember one thing, that pan-acinar is seen in alpha 1 pan-acinar is seen in alpha 1 antitrypsin deficiency, and rest all other are seen in smokers. Now let us learn the mechanism closely. See, this is the structure of a normal acini. What will happen, that this acini will dilate and this will be acted upon by in the upper lobe. What happens is that in see here, what will happening is there in the upper lobe, the smoke is going on towards the upside. So here the proximal part which is coming in the contact, that is the central acini part, that will get dilated, but the distal part will still be working, and therefore gas exchange would be taking place. So this is central acinar emphysema. But on the other hand, what does pan-acinar emphysema? Why in alpha-1 antitrypsin deficiency is responsible for causing pan-acinar emphysema? Remember that alpha-1 antitrypsin is responsible for inactivating the substances that are responsible for bronchiectasis. So this occurs more commonly in the lower part of the lungs, that is the lower lobes. Why so? Because here there is greater number of leukocytes because of greater perfusion. There is greater number of leukocyte because of perfusion. Now if there is greater number of leukocytes, what will happen? It will need to be activated by alpha 1 antitrypsin, so that there is not much damage. But in actuality, what happens is that now leukocyte have a free run, and there is nobody to stop them, and then therefore they eat up the whole acini. That is why pan-acinar. So pan-acinar emphysema is seen in alpha-1 antitrypsin deficiency, because this is intrinsic kind of, and it is because of the deficiency of alpha-1 antitrypsin in our own blood. Now distal acinar, again this distal acinar irregular are seen in emphysema, but the irregular one is the most common histologically seen. Now we move on to the bronchiectasis. Now bronchiectasis is involving, if there is focal bronchiectasis, then it is manifest in form of obstruction. Then if there is bilateral upper lobe, that is to only bilateral upper lobe, both the lobes are involved, that means that we are dealing with cystic fibrosis. But if one of the lobe is involved, that is bone complex are found, that is only on one side there would be TB. Now we come on to the middle lobe. Middle lobe is referring to the capacity to reproduce, especially in the middle age group. Now we want children. Now for children, you require the sperm and ova. Sperm is absent because of congenital absence of Wash difference. So Cartagener's syndrome. They cause bronchiectasis basically by primary ciliary dyskinesia. Now, ova can be taken from Lady Windermere. Everybody wants to marry Lady Windermere. Why? Because she is high up in the social status. She is the queen. But she has to do one disgusting activity, that is to swallow the mycobacterium, cough. Now, in bronchiectasis, the lower lobes are exposed to aspiration. Whereas in proximal bronchiectasis, MWY, Monner, Cohen, William Campbell, and yellow nail syndrome that is involved in proximal bronchiectasis. Now we move towards interstitial lung disease. In interstitial lung disease, you have to remember that it is of two types. Interstitial lung disease is of two types. What are those types? UIP and NSIP. Just remember these words because it will be really confusing if you don't know the classification UIP and NSIP, because both are very much nebulous in their ideas. That is usual interstitial pneumonia, you will not get much information from it, and non-specific interstitial pneumonia, again you will not get much information from it. So we have to remember that in what is usual interstitial pneumonia, UIP, is also known as idiopathic pulmonary fibrosis. Just remember that in the CT scan finding we will see a honeycombing pattern. Whatever pattern you are seeing here, this is the honeycombing pattern. Now in NSIP, we have ground glass opacity with subpleural spacing. So just remember that UIP IPF is honeycombing pattern, and this is NSIP, that is ground glass opacity with subpleural spacing. Now you can see honey is used for boosting the immunity in our traditional home practices. So who needs to be boosted immunity? The old elderly individual. Now elderly individual should be given immunity. And also remember, would you give because elderly individual are already suffering from defective immunity, would you give steroids to them? No, we will not give them steroids because they are already immunosuppressed. So why we will give immunosuppressant? And they have fibroblastic foci, and this honeycombing that is seen is basically at the base of the lung. See, most of the changes radiologically that you will see is in the base of the lung. Now in NSIP there is ground glass opacity with subpleural sparing. So but it is occurring in a middle-aged woman. This disease is occurring in a middle-aged woman. Now middle-aged woman, this NSIP is happening. So when it is occurring in a middle age, so her immune system is quite good, so we can give steroids to reduce the inflammation, and this can be the treatment. Now so steroids. Now remember that elderly people are going to as said by the and die early as compared to the middle age. So how can you remember the drugs that are used in this? So remember that pir, if you have studied Sufi or heard about songs in Sufi, so pir means God, so pirfenadine, so God loving. So remember the elderly are God loving and they are in the 9th and 10th decade of life. That is in 9th, 10th decade, 9th, 10th decade. Now we move towards occupational lung disease. Now we come towards the occupational lung disease. Now in occupational lung disease, remember that in this what is happening is in silicosis upper lobe is involved more. In silicosis upper lobe is involved more. Silicosis upper lobe is involved more. Now also remember that Miner's disease is equal to Grinder's disease. Now see these are the lobes that are upper lobes that are being involved here. And now remember that there is and this is anthracosis, blackish deposition is this, and this is known as anthracosis, and this is occurring in also known as coal worker pneumonocosis because it is occurring in coal worker. Now Kaplan syndrome, remember Kaplan and Erasmus both are the syndromes. So in Kaplan, you will have rheumatoid arthritis plus Kohlberger pneumoconiasis, and in Erasmus, you will have systemic sclerosis plus Kohlberger pneumoconiasis. See, Erasmus, we have Rus, it does not have E, empty of Rus, empty of Rus. See, normally our skin is what? It is lubricated by sweat gland and sebaceous gland. But what happens in Erasmus is there is systemic sclerosis, and sclerosis there is hardening of the surface. When there is hardening, so that means it does not have any rust in it. It does not have any तरल पदार्थ हिंदी में कहें तो उसको Erasmus is basically systemic sclerosis. Now Kaplan. Now in Kaplan you can remember R is refers to red and complain. When you are given a red card, then it is like complaining also. See, I'm telling you this here red also because you will see in radio also red. It is red in color, and this is the radiation absorbed by a particular thing that is measured in rad. So by that you can remember that rad is associated with Kaplan. Now we move on to the uh, other part of this disease, that is we get this is looking like a holly leaf. Now what we get holly leaf sign on x-ray, holly leaf sign. And also remember that if there is some mediastinal shift you are seeing, then it is not a case of asbestosis. Why? Because remember, usually pleural pathology, whenever there is pleural pathology, there would be shifting of the mediastinum, but in asbestosis that does not happen. Okay, now in mesothelioma, base of lung is involved, and therefore it is known as frozen hemithorax. And now remember that we get dumbbell like plaque here. In this you get dumbbell like plaque, which is seen in gross features asbestosis, something like this. Now remember that, see, serpentine and amphibole. Just remember that in serpentine is chrysolite, and that is good. See, because serpentine is, just remember that serpentine is on land, it is not entering in the water, so you know that it is on land, and you can easily catch the snake and kill it. But in is it also known as chrysolite, because crystal form remains when there is dried form, something like that, you can calculate. Now amphibolite is what? That is living both on land and water, so they are adaptable to both the conditions. So it is difficult to catch them, because when you go on land they will get into water, when they get into water, when you get into water, they get on the land, so it is very difficult to catch them. So therefore it is have bad prognosis. And now we'll mesothelioma. Now mesothelioma will have slender and thin gland giving out secretions, whereas in adenocarcinoma there will be only short gland. This is short and stubby. Short and stubby. This is slender and thin. See why it is short and stubby? Remember that glands here the glands are giving out secretions. That have stored in it. They need to be short and stubby. Now this is adenocarcinoma, so it will be napsin A and TTF1, which I will further discuss when we discuss lung cancer. Now other thing that you should remember is that when there is many times we get egg cell calcification. Now we discuss the berylliosis. Now berylliosis is seen in when in jewelry or dental alloy granulomatosis. B left is used. See, in berylliosis, it mimics sarcoidosis. Now, berylliosis is seen in which conditions? See, jewelry, dental alloy, granulomatosis. We have B left, beryllium LPT, which is associated with HLA-DP. Now, cobalt. Cobalt is seen in diamond industry. Now here we had done this glands in adenocarcinoma. The glands are short and stubby, whereas in asbestosis it is slender and thin. So here I will try to convey to you the difference between adenocarcinoma and asbestosis. See, in adenocarcinoma, asbestosis, not mesothelioma. Now what is, because asbestosis ultimately caused mesothelioma. Now what happens? What is the difference? See, remember, asbestosis, we have to carry out mining all day and night. so you will have to call in the night time. So what in Hindi we say, call रात में भी करनी पड़ेगी. So the marker is call retinine. Whereas in adenocarcinoma, this is all negative. And remember that SV positive in mesothelioma, S for cytokeratin and V for vimentin. SV, those who are serving, working all the night and calling in the night time, that is associated with mesothelioma. In adenocarcinoma, remember TTF and napsin. TTF1 napsin, it is positive. And carcinoembryonic antigen is also positive in adenocarcinoma. Now we move towards egg cell calcification. See, normally remember that in egg cell calcification, what is happening is that what are the situation when we get egg cell calcification? That is silicosis, most common, sarcoidosis, post radiotherapy, post irradiation lymphoma, histoplasmosis, blastomycosis, amyloidosis, tuberculosis. So remember how you can remember. We are saying that it is egg cell calcification. So let us bring some egg. So this egg is being broken. Now when egg is broken, so there would be some protein part, we can call it an amyloid part, and then there is yellowish part, we can call tuberculosis, because we have yellowish sputum when we cough in tuberculosis. Now see, there is a balu, and balu is also known as silica, and that gives rise to silicosis. And we have this magnet separating from the balu, and that is, from this we can think of sarcoidosis. And remember that this egg got broken because of a blast, and therefore this is blastomycosis. So you can recall egg cell calcification, that is blastomycosis, protein amyloid, TB, the yellow part, and if there is TB, then histoplasmosis is similar to TB, so that can also occur. And then we can remember lymph node. The real reason is, okay, fine. One more thing that I would like to add, that the real reason between serpentine and amphibolite is that serpentine, being snake, it cannot enter the lungs. It remains in the bronchiole, it's in the respiratory tract. Then from that also you can remember that serpentine, it will be only on the one side of the barrier, that is, it will be only on inside the bronchioles and will not go into the towards the alveoli. But what happens in amphibolite are finer. And also you can remember that amphibolite is capable of living both on land and water. So your trachea becomes your land, and your blood exchange that is taking place where in the alveoli, so that becomes water. So there is so it can reach up till the alveoli, and anything that reaches till the alveoli then and is more smaller in comparison to serpentine, therefore it will cause more harm. So therefore amphibolite is dangerous than serpentine. Just remember that. Now I'm going to start the most dreaded portion, yet easy if you go through the mnemonics I'm going to give you. Now carcinoma lung, how you can remember carcinoma lung? See, first of all, carcinoma lung, what are the types? Squamous, small cell, adenocarcinoma, and large cell. Remember, squamous cell carcinoma have all P. Now squamous cell carcinoma have all P's. S have all P's. So it is associated with Pancoast tumor. It is defective with P53. Now since it is P53, so defective P53 will marker as P40 and P63, that is on the both side. Now then we have keratin pearl, and then they says have parathyroid hormone related protein high, and therefore we have hypercalcemia in paraneoplastic. Now we come towards the small cell carcinoma. Now small cell carcinoma is this is most common hematogenous. It is central, and all the smoking influenced cancers are SS, that is squamous small. Now we will have LMIC. Now this is paradoxical, that is LMIC is positive in small cell carcinoma. Now we have basophilic stippling as a party effect. Now we have marker. What are the markers in small cell carcinoma? And remember this is small. So Love and Kush, the children of Ram, Love and Kush, they were small. So small cell carcinoma. So Love and Kush. Now for love, you can remember LEMS, Lambert-Eaton myotonic syndrome. Kush, you can remember Cushing. And also from love, you can lub. Lub is that is filled with water, and which condition you will have filled it with water in SIADH. Now we come towards the adenocarcinoma. This is the most common carcinoma, and especially this is seen in non-smokers, and it is in this is peripheral. Now also remember that it can be example alka ka ras. Remember that for by that eg. Now eg if we are egfr alk and ka crass. Now we move towards the lipidic spread. And remember, in this there is TTF1. See, he's taking a nap. TTF. He became a ticket collector and he's taking a nap. And TTF, and his name is also known as Happu Singh. Now, Happu Singh character, if you have known, then what we call this Happu Singh HPOA, and taking the nap is napsin TTF. So if you remember Happu Singh is belonging to adenocarcinoma and he's taking the napsin TTF1. So remember that in this we have Trozius syndrome, and this, while we have HPOA and migratory thrombophlebitis, that is known as Trozius sign, and it spreads along the alveolar septa. What is the how is that possible? That see, this is alveoli. So this cancer will spread along the alveolar septa. This is known as lipidic spread. Now, these are some spottings that you should know. See here, this is keratin pearls, and this is salt and pepper like deposition. And this is seen in, and this is the Azopardi effect. And this you will see that this is spreading along the alveolar septa, as I explained it here. This, see, in this there it is spreading along the alveolar septa, and this is similar to this. So it is lipidic spread. Now here you will see there is something opacity in the top, that corresponding to it, they will give you a certain squamous cell carcinoma predisposition condition, and therefore this will be Pancoast tumor. Now we have migratory thrombophlebitis, that is known as Trozius sign, and then we have hypertrophic osteoarthropathy. This is seen in Happu Singh was seen in adenocarcinoma. What were the marker? TTF1 and napsin A. And with this, you see this Pancoast tumor. When Pancoast tumor can compress the sympathetic nervous system, and this can represent in Horner syndrome, and this is superior vena cava syndrome. Now there are some additional topics that I would like to go, because now for remember pneumothorax. Pneumothorax is what is the indication for surgical intervention of pneumothorax? The conditions are that is persistent air leak, failure of the lung to expand fully after tube thoracostomy, and for such patient thoracic surgical intervention is recommended. Indications for surgical intervention for pneumothorax include, pneumothorax, mine was a very bad diagram that was. Now this is somewhat look like lung. So what happens is that is in first there is this is the first lesion that is being produced that results in pneumothorax. So what will happen in pneumothorax? This lung will be getting compressed. It will show that there will be filling up of the air. Now air would fill in these spaces in between. So what happens? See, then there is second ipsilateral pneumothorax. If this is the first incision, and again the next pneumothorax happens in the second subsequent time on the same side, then also we have to do surgical exploration. If there is contralateral involved, then we have to do first contralateral pneumothorax of if both bilaterally are involved, or pneumothorax is relieved even after by chest tube drainage, because when chest tube drainage fails, then we have to go and see that what is the cause of fail, and we have to go and correct it. Now spontaneous hemothorax in professional at risk like pilots and divers, and in pregnancy. So this was regarding primary pneumothorax. And also remember that if the rim size is less than 2 cm and there are no symptoms, then just observation. But if the rim size is greater than 2 cm, then we have to aspirate the air. And in secondary pneumothorax, remember that if rim size is less than 2 cm and if there is no symptoms, then also we can have to go aspiration of the air and also use high flow oxygen. But if the rim size is greater than 2 centimeter and if there are symptoms such as breathlessness, tube thoracostomy should be done. What are the surgical interventions that can be done by through VATS, that is video assisted thoracoscopic surgery? In this, what we do pleurectomy, pleural abrasion, chemical pleurodesis. Now, we depends also discuss different types of disease special circumstances. For example, in if HIV patient is given, see in if in a HIV patient is given, and when it is very clearly see whether that is the productive cough or non-productive cough, because on a time if you solve a PYQ, you will see there is a question in which HIV patient presents with protective cough. Now, as soon as we see HIV patient, we jump towards pneumocystis jirovecii, but we have to wait and learn that and listen that in pneumocystis there would be non-productive cough, and if there is productive cough, then it will be mostly because of Staph aureus. Now we come on to the non-productive cough. So in this, what are the conditions that are more likely? That is pneumocystis jirovecii. And what happens in this is this chest x-ray is normal. There would be absolutely chest x-ray would be normal. In CT you will get ground glass opacity. Now in bronchoalveolar lavage, that is pathognomic, we get foamy alveolar infiltrate plus mononuclear interstitial infiltrate, that is pathognomic. And now cotrimoxazole treatment is by cotrimoxazole. But remember that if PO2, now if blood PO2 goes less than 70 millimeter of mercury and alveolar arterial gradient is greater than 35 millimeter of mercury, that means the alveolar, this is alveolar and this is the blood that is flowing in the pulmonary artery, this is arterial pressure. Now in if alveolar arterial pressure is greater than 35 millimeter of mercury, then it indicates that a lot of fluid has been deposited in between the alveoli and the blood. So what we will do, we will give steroids to suppress it and to reduce the inflammation, and therefore corticosteroids are given. And also there are certain things that you will solve questions. So whenever there is hyperresonance, it is given. Hyperresonance is found by the air, so there is, it indicates that it has a lot of air. So lung will have a lot of air in two major condition, that is outside the lung but inside the pleura, that is pneumothorax, and also in emphysema where itself alveoli has been destructed, but yet they have lung taking capacity increase. Crackles are seen in pulmonary edema or pneumonia. Now stridor is a indication of obstruction, and this occurs in upper airways, usually tracheal or laryngeal. See, in this question only, if after you treat pneumocystis, there will be a situation that they will ask that what will you do, whether you will start if you treat it, if for example a TB patient comes with HIV, so what will you treat first? You will treat first the TB patient. TB, you will give first ATT, and after 2 weeks you will start ART, because there is possibility of iris syndrome, immune reconstitution inflammatory syndrome, if we use ATT. So now we have discussed here alveolar arterial oxygen difference. Now if a question comes that a patient is coming with hypoxemia and there is normal alveolar arterial oxygen difference, so what is this? See, if they are saying that alveolar arterial oxygen difference is normal, that means that there is nothing intervening between alveoli and the pulmonary artery. So if that person is suffering from hypoxia, so that means that he is not respiring enough number of times, and that is why it is a manifestation of hypoventilation. See, if a question comes, you always follow a dictum that in all the neurological, in the thorax you have to remember that there is, we do CT scan, but we become little choosy when we are using radiology for the posterior mediastinum. What we will do in this is posterior mediastinum. We will do MRI, because there are a lot of neurological structures. Now remember, for commonly acquired pneumonia, we have azithromycin as the drug of choice. If you remember, FABD we had discussed in the antibiotic thing. Now ventilator associated pneumonia. So how we will remember this? See, ventilator. Now ventilator is what? The room will definitely will having the AC. Now AC is pneumonia. Then we have AC netobacter. Now if some question is asked, that is in which they ask the difference between cardiac tamponade and tension pneumothorax. So how will you differentiate in between cardiac tamponade and tension pneumothorax? Don't jump on the thing that as soon as you see cardiac tamponade, you will see muffled heart sound, because in tension pneumothorax the heart sound would be there, but there would be more categorical is that in tension pneumothorax there would be absence of breath sound, because no breathing is happening here, the absence of breath sound. So from that feature you will mark that the absence of breath sound is the that is breath sounds are the hallmark for differentiating the cardiac tamponade and tension pneumothorax. Now more on respiratory, you would see tropical pulmonary eosinophilia often is given, in which this is a type 1 hypersensitivity. What is organ transplant hypersensitivity? Please write it in the comment section. And then we have reason for India having tropical pulmonary eosinophilia, that is 300 per microliter, and we see the restricted changes in the lungs, and microfilaria is sequestered in lungs, therefore it is not found in blood. What is the drug? Drug is 4 to 6 milligram per kg for 14 days. Now we come towards a question that is there. A 35 presents to with fever, breathlessness, cough with expectoration seen. What is the most likely diagnosis? Now this is what is saying. See, this is showing a consolidation of a part of the lung. Okay. Now this is known as air bronchogram. Now remember that this is middle lobe pneumonia caused by Klebsiella. See here the very fine middle lobes and fine fissures that is involved. Now this is the lobe is involved, so it will be by Streptococcus pneumoniae. Now see, this is the pneumatocele, that's why this is Staph aureus, and this is pleural effusion. Why pleural effusion? Always remember the absence of costophrenic angle. So here the it is becoming blunt, so costophrenic angle is not there, and that is required for making the diagnosis. Now question is often asked, that is what is the difference between typical and atypical pneumonia? Now for typical and atypical pneumonia, remember that in typical pneumonia the organism will be extracellular. There will be alveolar exudate, high grade fever, productive cough for typical pneumonia, pleuritic chest pain would be there, and X-ray shows large area of consolidation. So what happens in atypical pneumonia? Atypical pneumonia is intracellular, it is interstitial, now LL lymphocytic, and low grade fever. Now it will have dry cough, scanty sputum, and X-ray will show interstitial involvement. Now a question was asked that which of the following does not lead to ARDS at a blood-lung interface. So now which of the following conditions will not lead to ARDS at blood-lung interface? Okay, what happens is pneumonia, fat embolism, third is sepsis, and then fourth is Trali. So in which you will see blood lung interface involvement, so it will be happening in pneumonia. There will be no involvement. In ARDS there would be no involvement, but in fat embolism sepsis blood lung interface would be involved. One thing more that is often asked is extrinsic asthma and intrinsic asthma. Just remember that whatever we are learning, we are traditionally seeing, that is extrinsic asthma. Whatever we are seeing, that is extrinsic asthma. That is we see in children that have atopy. Now atopy seen in childhood, it is eosinophil mediated. IgE is raised and it responds well to steroids. But in intrinsic asthma, everything is vice versa. What happens is that there is Samter's triad, and it is non-atopic, non-allergic, idiosyncratic asthma. It is occurring in the adults. It is neutrophil mediated. It has normal IgE level, and it has superantigen Staph aureus enterotoxin involvement. decreased response, and the prognosis is often bad. Now we also see that there is what are the tests for our respiratory distress syndrome, for what are the tests that we can when we can do that, so that as to prove that lung is not fully matured. That is, first is Nile blue test. Nile blue test, remember that it, although it is Nile blue, greater than 50% of orange cell. Second is lecithin upon sphingomyelin. Lecithin upon sphingomyelin is greater than 2. Shake test. Now shake test, bubble test, that is amniotic fluid with 95%, and ethanol there is ring of bubbles. Now we come on to the most one more part, that is cystic fibrosis. What happens in cystic fibrosis is that, remember that cystic fibrosis, sat is coming. The word sat is being, when we speak cystic, instead of six, think of seven, and that seventh chromosome is involved. And what are these genes? That is CFTR gene is involved. So in this what happens is that, what are the diagnostic tests? What is the screening test that is often asked with cystic fibrosis? So remember that first is immunoreactive trypsinogen is used for screening. See, for any screening method, it has to be easily done. So what happens is that trypsin enzyme is not being able to pushed out of the pancreatic duct. So what happens is that when trypsin is not being going into the digestive system, so it accumulates there, and then trypsin then comes in the circulatory system, and once it comes in the circulatory system, then it is immunoreactive, because for our blood, this is a foreign body, so it will be immunoreactive trypsinogen. Fine, if we see immunoreactive trypsinogen, then this is a screening method for cystic fibrosis. Second, but what is the diagnostic test that we do? See, diagnostic should show directly the disease pathophysiology. So what happens is that chloride is excreted in excess. Chloride is excreted in excess outside the cell, and therefore sweat chloride test. In sweat chloride test, it is 60 millimole per liter is diagnostic. And remember, genetic testing. Genetic testing is gold standard. Now, what is the diagnostic criteria of cystic fibrosis that can also be asked? Number one, clinical system affecting at least one organ system, that is respiratory, gastrointestinal, or genitourinary. Now, as you have said, the diagnostic test, what we have, immunoreactive trypsinogen, and for sweat chloride test is used as a diagnostic test. For screening is immunoreactive trypsinogen. Genetic testing is gold standard. Nasal transepithelial potential difference can be estimated in equivocal cases. What are the diagnostic criteria? At least one of the organ system is involved. The positive newborn screening, that is, this immunoreactive trypsinogen is positive, and also a sibling with cystic fibrosis. Now we have to also prove that there is evidence of dysfunction of the CFTR gene by 2 positive sweat chloride tests obtained on separate days, or identification of 2 CFTR mutation by genetic testing, or an abnormal measurement of the nasal potential difference.